Hello, everyone. My name is Mike Akaraphanth, and I am a third-year medical student at the University of Colorado School of Medicine. I will be giving a case presentation for the radiology imaging elective here up in Fort Collins. The case report is titled Acquired Wandering Spleen Phenomenon with Splenic Torsion in the Context of Idiopathic Thrombocytopenic Purpura. So before we begin, we have to ask ourselves, what is the wandering spleen? And so the wandering spleen is a rare condition where the spleen becomes hypermobile from either congenitally absent splenic suspensory ligaments or just weakened ligaments from that holds the spleen tethered in place. The image on the right is a radiopedia image of a coronal abdominal CT scan that's normal with 88 labeling spleen. And so the idea is that with the suspensory ligaments that we'll review that is no longer in place, the spleen will be able to roam around in regions of other regions of the abdominal cavity, even pelvic regions. The issue is, and the reason why this is potentially a life-threatening condition, is that even though it's no longer held in place with these suspensory ligaments, the vascular pedicle that's attached to that houses the splenic artery and splenic veins has a higher risk of mechanical torsion, as you can imagine, as it moves around there, twisting on itself and causing possibly splenic ischemia, infarct, and potentially life-threatening hemorrhage. Some brief anatomy of the spleen. It's the largest reticuloendothelial organ in the human body. On average, an adult spleen weighs 150 grams, measuring between 7 to 11 centimeters, and lies in that left upper quadrant or left epigastric region between the stomach fundus and diaphragm at the level of the 9th and 11th ribs. It's anchored by a bunch of splenic suspensory ligaments, and it's emphasized here in this anatomy image or picture. So the spleen isn't actually shown, but what is shown are these kind of splenic suspensory ligaments, such as the gastrosplenic ligament right here that is tethered from, it's a perineal fold that tethers the greater curvature of the stomach to the spleen and houses some vessels. The phrenicocholic ligament that attaches from the left colonic flexure to actually the left diaphragm, serving as support. And the splenocholic ligament, again attaching from the left colonic flexure to the spleen and anchoring it in place. Here's a different image just to really emphasize now that you have a spleen, but also look at with all these suspensory splenic ligaments kind of holding it in place and anchoring or tethering it. Other thing to note is that some of the organs in the area that keep it together, such as the left kidney and adrenal gland, the tail of the pancreas. We'll go over the vasculature really quickly for the spleen. It obtains most of its blood supply from the tortuous splenic artery that comes off the celiac trunk, which in turn comes off the aorta. The splenic artery is very tortuous, and you can really appreciate it splitting off into these other segmental arteries before it goes into the hilum, or this curvature I drew with this red line, before it feeds into the spleen. The splenic artery consumes about 7% of cardiac output, and the splenic vein comes out and joins the superior mesenteric vein into the portal vein. Here is just a representative image of the spleen itself. Here's the spleen, but the splenorenal ligament is important because it's a distal ligament, but houses the renal vein, the renal artery, and the distal pancreas, which will show up. Finally, idiopathic thrombocytopenic purpura. We're not going to do a deep dive in this, but it's just an autoimmune disease where your antibodies start to coat the platelets, specifically at the glycoproteins like some of the integrins. This in turn signals some splenic macrophages to come in and start consuming them, leading to patients with thrombocytopenia, and even in severe cases of ITP, you could actually have hepatosplenomegaly. And so, for the fun part, we'll start this case presentation as a 57-year-old multiparous G4P4 female presenting to the ED with a several week history of big intermittent episodes of left upper quadrant abdominal pain that is acutely intensified 48 hours prior to presentation with associated nausea. And so vital signs on arrival seem okay. Their blood pressure is fine. She is tachycardic with a pulse of 111. Some important medical history. She's got ITP. There was other things, but we'll focus in on some of this history. Prior surgical history. She had a prior lap chole, as well as a laparoscopic hysterectomy, thoracic spinal cord stimulator implant, and left thoracotomy with plication of the left diaphragm, leading to a paralyzed left diaphragm. Initial physical exam, there was some minimal discomfort on her left upper quadrant, but no rebound, no guarding, no perineal signs. And her lab work came back. She's thrombocytopenic at 71. Her lipase is mildly elevated, but notably, her hemoglobin's somewhat okay. She doesn't have an infection. Her lactate's actually fine at 0.54. So before, she's in the ED, she's getting abdominal pain. She's going to get an abdominal CT scan. But before we even go to the abdominal CT scan, this was her CT scan 46 days prior. And you could really appreciate a normally positioned spleen. The red arrows just kind of accentuate the boundaries, make it obvious. And this is a VR lecture, and so we'll go into that scan now. This will be an image that should all have seen before, just a abdominal CT scan. And we're just kind of coursing through, sure. And this was, again, 46 days ago. You could start seeing the liver there. Here's the spleen. It's positioned correctly, as well as some of the splenic vasculature right there. Great. So with virtual reality, the CT densities are conserved into the VR platform here. And so you could actually play with some of the colors based off those densities. And we'll intensify it here. And this was a color that was preset. And you could actually, to appreciate some of the other structures, and this is our little exclusion cube, so we could poke inside. Here's some of the beauty of VR. So we do see that spleen. It looks, I would say, somewhat normal. And just in case, I'll point it out with sear marker. So we're kind of going through. Yeah, it's right there. Liver is on the patient's right, our left. And so that's, normal CT scan for her at the time. You could trace the vasculature too. Great. So this is kind of a warm-up for the next scan, which I promise you will be a bit more interesting. And so now this is her CT scan in the present moment of the case. Now you could start to see, whoa, what's that? It looks like the spleen, but it's a lot bigger. The hilum is facing laterally, which is incredibly interesting. There seems to be some enhancement. I honestly can't see. But we do have the scan here that we will... I don't want to spoil anything, but let's look at the CT. Okay. Let's look at the CT. Bear with me. I'm sorry. So we'll look at the CT here. And what they're seeing is spleen is abnormally positioned. Here's some of the hardware on our posterior back, or posterior surface. Kind of moving forward. Liver starting to come into field. Oh, and that's interesting. I don't know if you guys saw that, but I'll mark it because I didn't know what this was. But you can really start to appreciate this really weird whirl-like pattern there. I don't know what that is yet, and I'll be honest, I didn't know what it was before kind of reading into this case. And really, we could appreciate that spleen just Totally different positioning now. See there. Let's get rid of all this other junk first. So what I'm trying to reference here, that might be obvious to you all as well, is just that hilum where the vessels are supposed to go in are now facing laterally, which makes no sense. Because 46 days ago it was normal. So with normal vessels as well. Interesting. We'll go through for the sake of completeness, just kind of going all the way through. Okay. Well, I don't know what that swirling pattern is, and let's kind of investigate a little bit further. I think most of you all could already guess, but the thing about virtual reality is that you can really change some of the color schemes to optimize what you're trying to look for in terms of that theme of density. So this is a different color scheme now. But as you can see, you can really start to appreciate some of these vessels in a very, very complex way. Oops. So now we're looking coronally, but still we could appreciate those vessels, right? And even just the anatomy, and you play around with the histogram to get this image. So let's orient ourselves. So this looks like that's the aorta going down, and if that's true, you could follow it. That first outpouching there is probably the celiac trunk. And if that's true, if my anatomy is correct, that should split off and bifurcate there, that being the proper hepatic on the patient's right and the splenic artery on the patient's left. And also, you could see a little branch coming off, being the left gastric somewhere. That's probably it. So let's follow the splenic artery, because that's probably the main problem. You know, it's a little hard to follow. It's getting lost in all this fuzziness, right? So I don't really know what's going on. And this is SMA, and it's going over what appears to be the left renal vein. And that's probably the connection of the splenic vein going into perhaps hepatic. Let's just confirm to be sure. But I mean, very beautiful, color scheme and scan. And so the additional beauty of this, in my personal opinion, is you can start to manipulate things in free space. So let's look laterally, because I think there was a really good image here. So golly, look. And so if you could see the aorta there now, and I'm just going to orient myself so we all know. The aorta kind of coming here, I mean, that's probably the celiac trunk. Oh, excuse me. Which means that's probably SMA, right? So let's follow that celiac trunk to see what's going on. Because I want the splenic artery. So let's follow it. Okay, so this is probably the left bifurcations going here. Oh yeah, now I could follow it a little bit better. It looks like it's connect down there. Great. So I'm looking at that kind of large portion, or longitudinal portion going up and down. Great. And oh my. And you can see it kind of even goes to the patient's right or back from us, and then goes here. And what is this? Look at this sort of dance of what I assume now, or can confirm with this tracing, the spinal artery and probably the spinal artery, the splenic artery and the splenic vein. Look at that kind of twisting and turning as it approaches the vasculature of the spleen. And so, yes, this looks like splenic torsion, and that's the spiraling we see, and we really do appreciate this from now the lateral view. And just to confirm our hypothesis, because I'm just a medical student, just going to draw a little bit. Oops. Just going to draw a little bit. And this kind of marker and point will be conserved, because now, let's draw it so it stays here. I'm sorry. Bear with me, everybody. There we go. So that pattern is in the scan, and it's a little bit more further out as well. So I'll just draw another one kind of here. If it's okay, if it kind of goes with the box. It doesn't. Great. That's okay. Anyways, we'll move this out the way. Let's bring this back here and bring our CT scanner. So let's bring our CT scan. Perfect. And bring this transparency down. So we'll go put it through the machine. Now, where's that swirling pattern I saw? Is it coming? Still pushing it forward. Still pushing it forward. Oh, there it is. Okay, okay. And look at that. Appreciate that swirling. Kind of goes a little bit more laterally, but I admit that was probably my placement of the marker, but we could confirm that swirling pattern is, in fact, the splenic artery and splenic vein getting torsed together from that malplaced spleen. Great. So let's go back to the case. So it looks like, and I think that's what the pathologist read as well. Excuse me. So the CT abdomen contrast scan showed that the spleen was abnormally rotated on its axis with the hilum in the lateral position, engorged hilar vessels that we probably saw, and both standard and that's supposed to be 360-degree rotation of the splenic artery and vein. There was also some heterogeneous enhancement of the spleen, strongly suggestive of acute splenic torsion. 2 hours later, the ED provider contacted general surgery, and general surgery saw them, and her physical exam has now increased to abdominal distension and left upper quadrantennus with guarding, no rebound. Vitals are still somewhat okay. Her BP just slightly elevated, as well as her pulse. And so the definitive treatment is splenectomy. And so this is an image with a pneumoperitoneum and a 12 millimeter port at the 12 millimeter umbilical port taking a picture. You can see the spleen essentially not the greatest looking, but really do appreciate the lack of splenic suspensory ligaments around the area. So for wandering spleen presentations, it's rare, but it can be asymptomatic and incidental finding. It can include nonspecific symptoms such as acute or chronic colicky, abdominal pain, dysuria, splenomegaly, or even some sort of palpable pelvic mass if it migrated all the way down there. The most common presentation, however, includes subacute abdominal pain with or without GI complaints. I mean, it is possible as well to be thrombocytopenic and anemic just because the vascular congestion that develops from that large spleen and compromised blood flow, sequestering all those red blood cells and platelets. Definitive treatment is splenectomy. There was an interesting report where 35 cases of these pediatric wandering spleens were managed with splenoplexy, which is maneuvering the spleen back into its correct anatomical positioning with Dexon mesh, or conservative management. And they reportedly did well. And however, splenectomy is probably the more definitive treatment, as well as these were chronic wandering spleens. Just because of the rate of reoccurrence with an acute wandering spleen or splenic torsion, it cannot be emphasized enough about post-splenic vaccinations due to the increased mortality that asplenic patients face from sepsis and bacteremia or just infections from encapsulated pathogens. And from a health and society standpoint, it's really sad, but through kind of combing the reports, it seems like the patient was struggling between insurance policies, and rightfully so. She was concerned of getting an outpatient CT scan a couple of days before her presentation to the ED. And I wonder, if she ended up getting or was able to get that CT scan, she might have been able to save herself going to the ED. Really quickly, for diagnosis and imaging, you use a point-of-care abdominal ultrasound and still see that whorl sign, or put color flow and lack color flow. So that's the spleen there with SP, and BL notably stands for bladder in this case report. And you just show how its migration can go all the way further from its original point. Most of the time, it's probably going to be abdominal CT scan. You can see that swirling that we really explored, and in a malpositioned spleen and kind of following the vessels. Um, of course, if those two are equivocal or there might be a lot of gunk and you cannot see anything or make a definitive diagnosis, you go to one of my favorite scans, which is a technetium 99 scan or 99M scan, which now radiolabels red blood cells or damaged red blood cells or tags them. And over time, they'll start to accumulate into organs where most of them do occur, which would be the spleen that would light up if you are suspicious about that diagnosis or you think the spleen is somewhere else, or even things like splenosis or an ectopic spleen. We're going towards the end of this presentation. I'll just say really quickly the epidemiology. This is a rare, wandering spleen is pretty rare. I think there's 700 or so cases since 1664 that's been recorded in PubMed. But with the pediatric predisposition, the idea here with the theory, with a third of these cases being less than 10 years of age with a 1-to-1 male-female ratio of these pediatric cases, is some sort of abnormal development of those ligaments from the dorsal mesogastrium failing to merge with the posterior abdominal wall. And thus you get multiple ligaments or suspensory ligaments being congenitally absent or weakened. The more interesting, I think, theory is that the majority of these cases are actually multi-parous female populations between 20 and 40. And the idea here is the increased estrogen progesterone, which in turn increase the hormone relaxin, and thus relaxin works on ligaments and supporting ligaments to be, I guess, for different terms, relaxed or weak to allow for the growing gestation of a developing fetus or baby. It actually increases its receptor on various supporting tissues as well in one experiment. And so with multiple gestations or multiple pregnancies, you could start to come to the conclusion that maybe even the splenic suspensory ligament is affected by this cycle. So going back, altogether, you could probably, I wonder if the mildly elevated lipase is from that ligament that contains the tail of the pancreas. But possible reasons for this: she did have ITP, which could increase her spleen size. She did have splenomegaly at 376 grams, and had perivascular changes on pathology report, which is conjunctive ITP. She did have multiparity for the reasons we discussed. And the paralyzed diaphragm was interesting, not because of the surgery, but also with the diaphragm that's paralyzed, it can be higher up when with the combinations of a weakened ligament system or suspensory ligament system with increased splenic mass. It allows for more momentum or inertia for that spleen to rotate and move around and eventually maybe even flip or torse. It is speculation, of course, and but an interesting case nonetheless. Here's some acknowledgments. I want to acknowledge my general surgeon preceptor, Dr. Travis Walker, who let me write up the case and learn about it and even get to meet the patient. Dr. Kate for spearheading the radiology course here at Fort Collins, and Samantha and Masha for helping me out on the VR sections of this presentation. This is a recording, so I can't take any questions, but thank you all for listening, and feel free to ask me any questions later.